evening, everyone, and welcome to our second parent education webinar in a series of 3 this month. My name is Gretchen Knob, and I'm the Regional Director, and I work out of our Camp Hill office. The Epilepsy Association provides programs and services to those living with and affected by epilepsy in 49 counties in the western and central part of the state. Our offices are located in Pittsburgh, Altoona, and Camp Hill. Our website and other contact information will be in the chat later if you would like to learn some more about our organization and reach out to us. The Epilepsy Association is committed to continuing to provide important services and programs to everyone affected by epilepsy. I want to thank you all for taking time out of your busy schedules to join us for this important workshop. We are happy to have you join us for tonight's webinar on anti-epileptic medications and their effects on moods and behaviors. I would like to turn it over to my colleague, Greg McConnell.
Hello, everyone. I echo what Gretchen said and thanking you all for joining us here this evening. Our speaker is our pleasure and honor to welcome Bridgette McCauley as our presenter this evening. Bridgette is currently a first-year pharmacy resident at Conemaugh Memorial Medical Center in Johnstown. She grew up in southwestern Pennsylvania, obtained her Bachelor's of Science in 2015 from Allegheny College, and graduated from University of Maryland School of Pharmacy in 2019, where she received her PharmD. While in pharmacy school, she was an active member in the College of Psychiatric and Neurologic Pharmacists, and this upcoming year, she is completing a second-year pharmacy residency specializing in psychiatric care at Fulton State Hospital in Fulton, Missouri. And with that, Bridgette, take it away.
Hi, everyone. So, as previously mentioned, I am Bridgette. I'll be talking to you guys this evening on epilepsy medications with the effects on mood and behavior.
You're welcome.
So the way that we're going to talk about this is we're going to start with the anti-epileptic medications as well as their side effects. Then we're kind of going to touch base on 2 different kind of diseases that you can see or adverse effects that can happen with these medications, which will be our antiepileptic-induced psychosis, and then we'll finish it out with forced normalization. So we'll start, as I kind of mentioned, with the side effects that you really see with these anti-epileptic medications. So as a brief overview, in the past, behavioral issues have been described since the 19th century in those with epilepsy. So it's been a well-known thing. Now, individuals with seizures are more likely to have some form of psychosis or any type of behavior or mood effect than those of the general population. So we can actually see that occur in 9% of the patients that have seizures versus only 1% of the general population. So that means that anybody that has seizures or epilepsy is 9 times more likely than the general population to actually have some type of psychosis. And one of the difficult things is that whenever we're thinking about seizures and epilepsy, our ultimate goal is to really achieve seizure-free state with the minimal side effects, which can be complicated with many of these medications. Whenever we look at the medications, though, what we always want to take a look at is, does the benefit of the medication outweigh the risk? So one of the major side effects that we really see in the meds are changes in mood and behavior, and it's very common. There were a couple of studies that have been done, and there was one in particular that really stood out to me, and it actually pointed out that of, I think it was almost 4,000 patients that they looked at, 7.2% of those patients actually reported a change in their mood or behavior while on the medications. And it was so severe in 13.8% of patients that they actually had to either change the anti-epileptic or seizure med or decrease that dose. So some of the effects that we can see on the mood or behavior can be, there we go, can be irritability or moodiness, which is the most common one. So that can happen in about 7% of our patients. So irritable kind of makes sense. We understand that. And whenever we think of moodiness, sometimes we think of just being difficult to really get along with almost. Next is the depressive mood. So this is the second most common. And what you can see here is just some sadness, feeling really hopeless, really tired all the time, or even an increase in some agitation. The next most common is our anxiety. Anxiety can just be seen as irritability, restlessness, difficulty concentrating, or even really feeling worrisome all the time and not being able to get away from this feeling of doom. Next is our aggressive behavior. So that can just be seen as an outburst, just whenever you really think of aggression. Next is the psychosis. So psychosis can be a little bit more difficult to kind of understand. This can be seen as our disconnection from reality is the big thing. So that could be our delusions, thinking something that might not necessarily be true, hallucinations, so seeing things or hearing things that aren't necessarily there, and also not necessarily even being able to form coherent sentences, so not making sense. Up next is our tantrums, which occur at 0.5%, so the same as the psychosis. And lastly, the suicidal thoughts, and that occurs in the smallest percentage of patients that take these medications. So the risk factors for actually developing these mood and adverse effects are primarily going to be if they have any type of prior psychiatric condition. The next part is failure to improve on greater than 2 anti-epileptic medications, which I see a lot of you had whenever we took a look at the initial poll of almost 40 to 50% having greater than 2. And the last very strong risk factor for predicting if you're going to have any type of mood or behavior effect is having particularly absence or secondarily generalized seizures. There was one moderate risk factor in a couple of studies, and that was just a history of static encephalopathy. Now, one big thing that I really want to point out that the literature really pointed to was that if anybody had a prior psychiatric condition, whether it be depression, anxiety, some type of like a bipolar disorder or a mood disorder, or even a behavior disorder, whatever that underlying condition was before the medications, that can really drive that adverse effect that we might see. So it's almost like making it worse. So if somebody has a history of depression, the medications are more likely to cause the patient to have depression on that medication. So the way that I next broke this up, it's a lot of information on these next few slides, but I think that it makes a very good resource. So I'm kind of going to be touching on a couple of the different signs and symptoms that we can really see. So we'll start with aggressive behavior. And as previously mentioned, as you can see here at the top, this can really be our aggression and tantrums. Those are two really big things that we can see. Now, the way that I have this laid out is over on our left-hand side, the top is going to be the medication that has the highest risk for this occurring, and then it goes to the bottom, over to the right-hand side, and down to the bottom again. So our most likely medication to cause any type of these aggressive behaviors are the Topamax or our topiramate. This has been shown in upwards to almost 82% of patients to have this adverse effect. One of the other big medications that I kind of want to take a point out primarily is going to be that Keppra or the levetiracetam. That can occur in up to 27% of our patients. Some of our other more common medications that we can see this with are going to be the gabapentin and the 13%, and even lacosamide or Vimpat in 8% of our patients. Now, the Klonopin, also known as clonazepam, or the phenobarbital, there is some case reports, so there's some information saying that it can occur, but there's no real numbers associated with that. And two medications are Dilantin, or the phenytoin, or the Lyrica, also known as pregabalin. Those medications do not have any aggressive behavior technically reported with patients taking those meds. And just at the bottom, I kind of wanted to point this out. I have Briviact. In a lot of the literature, it's just noted to cause psychiatric disturbance in 8% of its patients that take it. And they didn't separate it out on the aggressive behavior or some of the other ones that I'm going to mention. But what they found is that 8% of patients noted either irritability, anxiety, anger, agitation, depression, hallucinations, or paranoia. So our next category of mood disorders will be psychosis. So what psychosis really talks about is delusions. Frequently you can hear this as delusions of grandeur, having somebody thinking that they might be the president. Next is our hallucinations, so hearing or seeing something that isn't necessarily there, or paranoia. And that paranoia is this feeling that something bad is going to happen, or having this ongoing fear that somebody might be after them. So this doesn't occur in quite as many patients with the medications, but the ones that really did show that it happened the most frequently in were zonisamide and topiramate. Both of those, the zonisamide can occur in up to almost 19% of patients, and the topiramate, or the Topamax, can occur into up to almost 12%. Next is kind of going down a little bit further, we can see that our gabapentin, Vimpat, and Lamictal, those have a lesser side effect, and ultimately you can see there at the bottom on the right-hand side, Tegretol, Klonopin, Onfi, Trileptal, these do not have any reported incidents. And what it means on the one before that with the phenytoin, with the toxic effect, if you get too much of that medication in your body, that's whenever you can see the psychosis. Up next is our hyperactivity or restlessness. This here can be seen in ADHD and insomnia. So ADHD, we're going to be seeing a lot of fidgeting and difficulty focusing. The medication that can cause this most frequently is going to be our phenobarbital. It can occur in anywhere from 10 to 42% of our patients. Next is the Onfi and the Sabril. Those two kind of follow up between 25 to 27% of patients occurring in. And then the Klonopin, carbamazepine, and the lacosamide are just there slightly thereafter with right around 12% of patients experiencing these adverse effects. Now, there are quite a few of medications where we don't necessarily see those in, as you can see there on the right-hand side. And what's interesting is the levetiracetam, or the Keppra, has been seen in the higher categories in the previous ones having more adverse effects, but this one isn't quite as bad for a hyperactivity or restlessness. And lastly for this is our behavior and mood disorders, so our anxiety or depression. Most commonly, this occurs in Topamax. It can occur in up to almost 44% of our patients. And then following shortly thereafter is Onfi or clobazam, and then the ethosuximide. The medications then quickly drop off in terms of how frequently it occurs, going to the clonazepam and the Keppra and the Lamictal thereafter. Now, I know that this is a lot of information on these slides, but I just think it can provide a pretty good reference moving forward. Now, one medication that I didn't mention in any of these previous slides was Epidiolex. And this medication is newer and is being used more frequently now, so I at least wanted to have a little bit of information about it as well. what's important to note is that this medication does differ from medical marijuana. And the way that it does is it's actually a cannabidiol extract. And what that means is that it doesn't have any mind-altering properties, whereas medical marijuana can contain THC and CBD. And what that really means is that THC has those mind-altering properties. So, for instance, can give you more of that out-of-body experience that you typically think about whenever you hear marijuana. Now, the most common adverse effects whenever they were doing the initial studies to get this medication approved by the FDA was agitation and irritability in up to 9% of the patients, and aggressive behavior and outbursts in up to 5% of the patients. So just to kind of finish this out with our overview of our medications, the two, whenever looked at under a larger picture, that had the highest potential for adverse effects in regards to mood and behavior were really our Keppra, which was seen with the irritability, aggression, other behavioral issues, a depressive mood and anxiety, and the Zonegran, also known as zonisamide, for having one of the highest rates of individually depression alone. Now, our medications with the lowest potential were really seen as the Lamictal. It has our lowest risk for irritability and depressive mood. Our Tegretol has a lower risk for irritability. Onfi overall has a lower risk for adverse effects in regards to mood and behavior, but does have a higher risk compared to the carbamazepine or the phenytoin alone. And then we see here the Neurontin, Trileptal, the Depakote, and the Dilantin being considered our lowest potential for medications that cause our mood and behavior adverse effects. So whenever we talk about the treatment of the mood and behavior disorders caused by these anti-epileptic medications, the most important thing to really keep in mind is that we don't want to make any changes to the medications without first talking to your doctor. We want to make sure that while we're taking these medications, we recognize that these adverse effects can occur, but we need to talk to the doctor first, because whenever we discontinue them, there can be worse outcomes if we don't necessarily take that medication. One of the things that the physician will most likely recommend would be to either decrease the dose of the medication or switch to another anti-epileptic medication instead. So the next part of this presentation is going to be taking a look at our anti-epileptic-induced psychosis, and this is referred to as AIPD. So anti-epileptic drug-induced psychotic disorder is a side effect of medications that treat epilepsy. Whenever they were studying the medications to get them approved by the FDA, it actually showed that this occurred in 1 to 8.4% of those trials that they looked at. As a concept, it is not very well understood. And one thing that's really interesting about this is the diagnosis of AIPD can only be made after the episode of psychosis has occurred. So the definition of this AIPD is showing that you have to have delusions, which is thinking that, as I said before, almost like a delusion of grandeur, for instance, thinking that you're the president, or hallucinations that last at least one day, and you need to have either disorganized thinking, where you're unable to form sentences, or you're having what we consider grossly disorganized or abnormal movement. So this is aggressive behavior that's out of the ordinary or unusual social behavior. The unusual social behavior, consider somebody who's urinating in public. So the thing that's really important with this is that it must be at a separate time than the seizures that are occurring. So if the patient is seizing and having these delusions or hallucinations it doesn't meet this classification for the AIPD. And the other thing too is that it must occur during or soon after taking or stopping these medications. Now, the most important thing to really keep in mind here is that for this, it has to be severe enough to impact patient's social or occupational functioning. So are they not able to do well in school because they're too busy not being able to form sentences appropriately, for instance? So looking into the AIPD itself, there's been a couple of small studies, but I wanted to focus on this one in particular because it looked at patients that actually met this AIDP diagnosis. So in one small study that had the AIDP, it actually showed that the majority of the patients were actually just taking Keppra or the levetiracetam. The remaining patients were taking either the Lamictal or Keppra and Topamax, and ultimately the lowest percentage of patients were just taking Depakote or valproic acid. Now, the risk factor that they really found that caused patients to be more likely to have this AIDP was having temporal lobe seizures. And the hallucinations that the patients saw during this time frame were most likely auditory as well as visual. And the delusions that the patients were experiencing were that there was harm that would come to them. So they had fear that somebody was chasing them, after them, there to hurt them. And the one thing that I found very fascinating about all of this is that out of all of the patients that the AIDP occurred to, most frequently it was patients. It can occur between 60 to 75% of female patients whenever you look at those that have this. So whenever we looked at the psychotic episodes, they were less than a week in duration for about 43% of the patients, and no patient during these studies had to see any psychiatrist for long-term help. The treatment was to stop taking the medication that actually caused AIDP and try another anti-epileptic medication. But if the psychosis did continue throughout that time, you can try antipsychotic medications, which I'll touch on a little bit later. Our last concept that I wanted to touch on here is forced normalization. So this is a concept that has really fascinated a lot of neurologists for many years. It was initially described in 1953 by Dr. Landau, who actually coined the term of forced normalization. And what this really means is that as the seizures stop on the EEG, that's when the psychiatric symptoms begin. So I have a picture there of the EEG on the right-hand side. The one at the very bottom is whenever you can see the seizure actually occurring. So whenever you start to see a transition from that one on the bottom into the middle, that's actually when the psychiatric symptoms really began. Now, this doesn't occur very frequently, and it's expected to occur in about 1% of patients with epilepsy, but it doesn't matter if it is a child or an adult. You can see varying levels of consciousness with paranoia or psychosis, and one thing that's really interesting is that you can often have memory loss following the event that occurred. So frequently the patient won't even remember that this had happened. So there are a couple of risk factors again, which is going to be the temporal lobe epilepsy, our generalized and focal epilepsies. And it's very uncommon for this to actually occur in our patients with generalized tonic-clonic seizures and extratemporal lobe epilepsy. And one thing that we can kind of note is that with all of these risk factors for the side effects of the medications, as well as the AIDP and the forced normalization, is that it really seems to be the generalized and the temporal lobe epilepsy that seem to be at a higher risk for this. So the diagnosis for this forced normalization is you have to be diagnosed with epilepsy, and you have to have some type of behavioral disturbance with either psychosis, delusions or hallucinations, changes from mood, anxiety, or overall hysteria, and it must occur once that EEG really normalizes. So ultimately, the treatment here of the forced normalization is going to be stop that anti-epileptic medication, and if the symptoms persist, you can consider additional medications. Now, the ultimate treatment slide here is kind of a generalization for everything. One of our biggest concerns whenever it comes to our anti-epileptic medications is that there's a lot of drug-drug interactions that can really occur. It can be between any of the anti-epileptic medications as well as our antipsychotic medications, or those that even can help with our antidepressant and anxiety. So what the biggest two that they really found of our psychotic medications in our pediatric patients were to avoid clozapine, also known as clozaril, which is a pretty heavy hitter antipsychotic, and chlorpromazine, which is a bit of an older medication as well. They have the most interactions with the pediatric patients, and really the two that had the best effect as well as the lowest risk of worsening seizures in the pediatric population were both haloperidol, also known as Haldol, and risperidone, also known as Risperdal. Both of those medications are considered antipsychotics. And while they do have their own adverse effects as well, they're definitely proven to help in patients that are having symptoms that are persisting outside of adjusting our anti-epileptic medications as well. Are there any questions, anyone?
We do have some questions that came in the chat. If you're ready to take some of those now.
Yes, of course.
Okay. Okay, so the first one that comes up, and this is from Catherine, and she has a few questions in here, and we'll just go right down through them one at a time. Is there any information on the side effects of Aptium?
Of Aptium, I did not see anything in particular whenever I was kind of looking into this. I can definitely take a deeper dive into this, and I can forward you information as well on that if that would be okay.
Okay, we'll get that out to you then, Catherine. The second question, is there any information on the side effects of drug combinations, I guess, in general?
Overall, most of these studies that were really analyzing the adverse effects were really looking at the individual classes of the medications. Whenever you start adding more medications on, that's whenever you start to see higher risks of those adverse effects. And if you kind of go back a little bit within one of my slides, whenever you really see the charts, that's how you can really kind of get an idea for almost thinking of it as an additive effect, that you are starting to get like the higher tiers of patients that are going to have the psychosis or the mood and behavior disorders as well.
Okay. The last part to that question, is there any evidence that any of the drugs or combination of drugs can actually cause seizures?
In terms of the anti-epileptic medications?
That's Catherine, if you could respond to that. I'm assuming that's what the question is referring to, but let's give her a minute to respond to that, Catherine, if you could do that. She says yes. Yes.
Now, I'm not quite sure if, from what I understand and from a lot of my readings, I'm not quite sure that any of them actually worsen any type of epilepsy in this sort of situation. So I don't necessarily believe so. Our bigger concern is if we start to add in additional medications that are outside of these anti-epileptics, for instance, going and using our some of those different antipsychotics, those are what can really worsen our seizure control if we're not paying attention to the different interactions that can occur.
Okay, thank you. Next question up is, I'll read this all out. This is from Alicia. I just had the problem with my 13-year-old stop taking her Topamax, The side effects are bothering her too much. How do I help her gain trust in the medication again? I'm also looking for something to help with her migraines.
So the Topamax is a great medication because it really helps with both the migraines as well as the seizures. And it's one of those medications, especially being 13, you don't necessarily want to be taking a lot of medication. So it really is important to try to take that because it should help with both of those, and really not wanting her to have to take a bunch of different medications. Now, if she didn't necessarily like the side effects, my question would be, what kind of side effects was she really experiencing? Like, did she have a lot of insomnia? Because if she had the insomnia, maybe taking the medication earlier in the day might help with that as well.
Okay, great. Thank you. Next question is from Tobin. Any discussion of medications to counteract hyperactivity, nonstop energy, lack of focus, which may or may not be because of the seizure medication?
Mm-hmm. So one of those things that we really have to kind of keep in mind is maybe the patient is having some ADHD as well in that situation. So I think having a conversation with the neurologist who's really helping to manage those medications, the concern that the ADHD might kind of be forming. There's a couple of medications that are out there. I didn't look much into the interactions between ADHD medications with the anti-epileptics, but there are a lot of options that are out there for the ADHD that should help as well.
Okay, great, thank you. Next question is from Stephanie. This one's a little long, I'll read through. Any medication recommendations for double cortex syndrome? We've tried Onfi, which was a failure, Keppra, which there was severe anger experience, Trileptal, allergic rash, Topamax, some cognitive issues, Depakote, failure and brain atrophy, and Briviact, currently on and having seizures, and Klonopin is a rescue medication, but still has seizures after taking it.
I sadly don't have much recommendations in terms of that. It's just such a difficult thing whenever you're having the seizures that really aren't controlled on those medications, but just keeping up with taking the medications as prescribed and working closely with the neurologist would be my best advice in that situation.
Thank you, Bridget. Next question came in from Alicia. What do you recommend for treating epilepsy and also depression? Are there common medicines used for that?
So there's a lot of medications that can really be used for the depression as well as continuing the anti-epileptic medications. So I think something that's important is, especially if you already know that there is the risk of the depression, going for a medication that has a lower risk of that. For instance, the Trileptal, for instance, or the Depakote. And then you can take a lot of different medications in terms of, there's so many out there for depression nowadays. One of the ones that I mentioned briefly wouldn't necessarily be a first-line option, but the risperidone, for instance, has a lot of efficacy in helping with mood side effects and doesn't have many interactions with those medications. There's also our SSRIs or our SNRIs. Those are considered basically those help produce serotonin within our brain. And the serotonin is what we consider our happy hormone almost. But things such as sertraline or Zoloft or fluoxetine or Prozac, all of those are many medications that can be used to help with depression as well.
Thank you. Next one from Jana. 12-year-old daughter on Keppra XR after getting Stevens-Johnson's on Lamictal. Exhibited depressive tendencies when the switch occurred mid-March. Not sure if the depression is from medication, isolation, and quarantine, just going through puberty, or a jackpot of all three. New diagnosis as of February this year, new to all of this.
Okay. I would probably say that you got very lucky and had the jackpot of all three in that situation, having all of that. And what I've heard with Steven Johnson is it is not a pleasant experience by any means. So I'm really sorry to hear that, but I think the biggest thing is quarantine is starting to wind down a little bit. Maybe being able to get outside a little bit more and doing things that your child enjoys might also help a little bit as well.
Great. Thank you. So we have a question here. Last one in the queue right now is from Mia. How long were the patients on a medication after reporting adverse effects? This might be to the group in general, but I have to say you will see side effects that do go away eventually if you can ride them out. If you have anything to add to that.
Yeah, a lot of the adverse effects that I really saw occurred in patients between, I think it was really 12 to 18 weeks was really is what most study periods really look at for those. Longer term, I really didn't see a lot of information, but it really does depend individual to individual and how much those adverse effects are really impacting that person's life. If, for instance, you're not able to really get across to your child and they're not making any sense and they're having really severe hallucinations where they're seeing things and hearing things, that's a situation where you might want to consider getting off of that medication sooner versus whenever they're having more mild symptoms.
Thank you. Another question from Stephanie came in. Can you speak to the potential life-threatening rash with Lamictal?
So the Lamictal rash that occurs, it's pretty uncommon. But the biggest thing is as soon as you do start to see the rash occur, it'll start to look a little bit red. It's really important to go ahead and go to the doctor as soon as possible. And that's kind of the max of my experience. It is really uncommon. Stevens-Johnson in general is a pretty uncommon but serious adverse effect. And the most important thing is to go to the doctors or the emergency department and let them know that you think it's because of that medication.
Okay, thank you. There are no other questions in the queue pending, so we can, if you have anything else that you want to say as kind of a wrap up, Bridgette, or Gretchen, if you want to add anything at this point. But Bridgette, we definitely thank you for presenting today and for the great information that you shared with all the people on the meeting here. So thank you for your time and expertise.
And I just wanted to say thank you for everybody joining me this fine evening. I really appreciate it, and I hope everyone learned a good bit as well.
I certainly did. I know that.
Yeah. Thank you so much, Bridgette. I appreciate it. It was a lot of good information. I want to thank you again, Greg, for your help with this.
Thank you, guys.
Thank you. Thank you, everyone. Have a good evening.